Good morning. Good morning, everyone. Please come in. Welcome to iCAAD third day, Wednesday morning. My name is Christophe Sarvan. I am the academic director of iCAAD and CEO. I am going to make a very short introduction because we have a very dense session today. This is what we call in our team the high-flying psychiatric session of the conference, and it's been made possible with the support of Nightingale Hospitals London and the Sinue Group, the mother company who is partnering with iCAAD in Paris, in London, to promote state-of-the-art innovation in modern psychiatry. To cover this vast topic in two specific domains, we have two prominent psychiatrists from London today, Dr. Pertusa, Dr. McPhillips. You probably know them already from different other conferences, iCAAD in the past. Dr. Pertusa, who will speak first. Oh, you're speaking first? Oh, sorry.
I thought I was.
You want to change again?
No, sorry.
I don't mind. Okay.
It'll cause a real problem with the presentation.
No, it's already.
Oh, you're first here, Alberto.
Yours is the next one.
All right, sorry. Maybe should.
That's all right.
Please carry on.
Okay. Don't shoot the postman. So, Alberto, you are an extensive academic and clinical psychiatrist. What I mean here that you have both a fantastic credential in academic research, but also a gusto and an experience into applying it. You work in the field of OCD spectrum, primarily. You are famous for hoarding theories and conceptualization, and we had a fantastic iCAAD talk 2 years ago, I think, about hoarding, and I think your PhD was about that. You work with the Nightingale Hospital, but also your private practice. And today you will specifically address ADHD and addiction and the way they co-arrive. So I'm not going to unveil anything about that. And Mike, thank you for being with us today. I think the best way to describe you is your curiosity, Mike. I've always been absolutely fascinated by the way you think outside the box. You push innovation, or you look at things without any preconceived idea. And I think this is what you are going to try to, with success, convey with us today about what does the future hold for addiction medicine, RTMS, vaping, baclofen, ketamine, psilocybin, many others probably, but these are the ones you're going to cover. We all have questions. Is this working? Is this ethical? Is this really the right thing to do? All those questions that are, I think, central. The last thing I want to say about you is that you always manage to find an approach to your patient between the mind and the body. Psychiatric medicine, physical medicine. And from a personal perspective, I've been really, really benefiting from your wisdom in that respect, in my own professional capacity. I leave it to you, and I just make myself scarce. Thank you.
Can you all hear me well? Wonderful. Pleasure to be here. Thanks to the organizers. Thanks to the Nightingale for this wonderful opportunity. I think ADHD and addiction is a fascinating topic and a very neglected one. So I hope this is going to change. No conflicts of interest. I don't get any money from pharmaceutical industries or anything like that. My clinical expertise in ADHD and addictions has been developed over the last few years mostly. And at the moment, I would say that most of my caseload is either addiction or ADHD, or actually the combination between the two, which happens very, very often. It's good to start with this slide because there's still quite a lot of people out there, maybe even some of you, who feel that somehow ADHD is, there's kind of, I call them ADHD denialists. And during this presentation, I'm going to address perhaps some of the reasons why some people may think ADHD doesn't exist. But let me start with something called the Dunning-Kruger effect, which you may or may not be aware of. It's what we call a cognitive bias. So essentially, if someone knows only a little bit about a topic, we have the false impression, we tend to kind of somehow oversimplify it, we have the false impression that we know a lot about it, and it happens in many fields, and it can happen to all of us. So many a time I've asked a patient that I suspect may have ADHD, have you ever been tested? And they'll often say, well, I know for sure I don't have ADHD, for example, because I'm not hyperactive, ADHD, attention deficit, and hyperactivity. So that's all they know. If they don't have attention deficit or hyperactivity, they think they don't have ADHD. But then, as you probably are aware, you don't have to have physical hyperactivity to have ADHD. It's just one of many criteria. You can have brain hyperactivity, or you can have many other symptoms. So no two people with ADHD are the same. So the one-size-fits-all approach doesn't work, and a lot of people perhaps have this kind of very clear stereotype of ADHD being someone with hyperactivity and difficulty focusing. Whereas actually people with ADHD can focus very well, and sometimes too well, if they're very interested in something or if they're obsessed. They tend to hyper-focus. But when they want to focus on something that they find quite tedious or boring, they do struggle. They tend to postpone, procrastinate, and then last minute, the kind of panic monster kicks in. Their adrenaline levels raise, and they can hyper-focus, and i.e. cramming the night before an exam, and things like that. Differences between ADD and ADHD, we tend to use the two terms interchangeably, really, but essentially there are two big domains of symptoms of ADHD. One pertains to the so-called inattention domain, the other one is the hyperactivity or impulsivity domain. So if someone only has symptoms pertaining to the inattention domain, we'd say they have ADD. If they have symptoms of both or only hyperactivity, we say they have ADHD. The most common subtype is the combined one, where people have symptoms of both domains. So the DSM-5 criteria for ADHD, they divide ADHD again into these two broad domains. Inattention, which is kind of difficulty focusing for any length of time, procrastination, lack of organization, arriving late to places, finding it really hard to kind of be present in the moment, because you're distracted, forgetful, somewhere else in your own brain. So these are the criteria for inattention. You only need to meet 5 to meet the diagnostic criteria for ADHD. As far as hyperactivity and impulsivity is concerned, if you have 5 criteria, then you meet criteria for the hyperactive subtype. So only 2 of, if you pay attention, only 2 of these criteria for hyperactivity actually have to do with being physically hyperactive, being fidgety, finding it hard to sit down for any extended length of time. The other criteria have to do more with mental hyperactivity, what we call mind wandering, or a need to always be doing something, whether it's checking your phone, doing something, standing up, moving things around. People who find it very hard to relax, people who tend to be quite talkative, impulsive, impatient. And as you can see, there's quite a lot of overlap in terms of the substance misuse type of perhaps stereotype. So one of the key points that I'd like to convey in this presentation is that there is nothing that's absolutely unique about ADHD. Like if someone hears voices, it's quite clear that this is not a normal experience, and we attribute that to psychosis. But in ADHD, the majority of symptoms people with ADHD experience, we've all experienced them. I mean, we can all feel focused sometimes, distracted other times. We can all be impatient, scattered. We can all arrive late and procrastinate sometimes. So that's why perhaps some people think, well, I mean, that happens to me as well. Why do you call that ADHD? So the key is how often that happens, how severe it is when it happens, how much it impacts your daily functioning, and whether it happens across all of, like, at least enough domains in your life, academically, personally, professionally, that you can think, okay, well, this person has enough symptoms, severe enough, and then they meet the diagnostic criteria. So the concept of a continuum or a spectrum, not just across one dimension, but across all of these dimensions, as many dimensions as symptoms there are, is the best way to conceptualize ADHD. So although insomnia is not a specific criterion for ADHD, the majority, or quite a lot of people with ADHD will say, I struggle with sleep a lot, I can't relax, my brain doesn't stop. And they tend to often use alcohol or sleeping tablets, or they can listen to an audiobook or watch TV, and that way that seems to help them keep that distracted or mind-wandering side of their brains somehow engaged in something, which helps them eventually pass out and just fall asleep. It's a very typical symptom. If I had to summarize this slide in one word, I would say ADHD does exist. It is a valid medical diagnosis. We have enough neuroimaging evidence. We know it's a neurodevelopmental condition. We know there's a delay in the maturation of some areas of the brain that have to do with our ability to pay attention, which is regulated by noradrenaline, and our ability to experience reward, which is obviously regulated by dopamine. We know it's very genetic, very heritable. It often runs in families. So I like to tell my patients that having ADHD can be a disadvantage in some aspects, certainly, but it can be an advantage in many other aspects. They tend to be, people with ADHD tend to be very driven, very endearing in many ways, very, very motivated, and they can be extremely successful because they have an ability to hyper-focus on certain things that they naturally thrive doing. So quite a lot of successful people have been diagnosed with ADHD. The prevalence of conditions like schizophrenia is let's say 1% in the general population. OCD can be about 1 to 2%. Now ADHD is much more frequent. It's between 2 and 5%. So it's relatively frequent, particularly in adults. Perhaps a more relevant question for yourselves: how many of your patients are likely or potentially could have a diagnosis of ADHD? How many patients with addiction tend to have or could have ADHD? And there's a wide range of prevalence, which is high anyway. The most recent studies are pointing more towards the 40% figure, and the differences in rates across studies is probably to do with how they define addiction and other methodological issues. But we know that about 1 in 3 to 1 in 5 people with significant history of substance misuse is very likely to have ADHD. That's a very, very high prevalence. Not only they're more likely to have ADHD. I mean, if someone has ADHD and addiction, we know that they're more likely to have started earlier in life in terms of their addiction. We know they have a worse response to treatment. And we know that there's a very, very big overlap at a genetic level and also kind of at a cellular or kind of neurophysiological level in terms of ADHD and addiction sharing issues with reward deficiency, with impulsivity, novelty-seeking behavior, the self-medication hypothesis for ADHD, and the kind of dopamine kind of reward system implication is quite scientifically proven nowadays. So let me just briefly talk about this study. Very recently published, very well conducted, using very sophisticated kind of genetic techniques. 85,000 subjects, complete genome analysis with ADHD. Essentially, the conclusion is that if you have ADHD and use cannabis, about 50% of cannabis use in people with ADHD is genetically determined, which means some people with ADHD are very, very hardwired to have a response to some drugs, in this case cannabis, that will reinforce a kind of a regular use of cannabis. So I think this is quite interesting and powerful information that could potentially be used in many ways in terms of psychoeducation, for example. People with ADHD can also have not just substance misuse, but much more risk of having anxiety, depression, and particularly borderline personality disorder, which often we don't think about because people with borderline can behave in ways that are sometimes quite extreme. So often the ADHD may be kind of missed in this population. Without going into much detail, there's quite robust scientific evidence that ADHD is associated with all sorts of negative outcomes, from more risk of divorce to more likelihood of going to prison to quite a lot of other very, very negative outcomes, such as, of course, substance use disorder, car accidents. So it's probably the not so well-known side of ADHD. It's really associated with negative outcomes. I mean, someone who doesn't have ADHD finds it hard to relate to this concept of brain hyperactivity. But if we think of a situation where we have felt very overwhelmed, juggling different things at work, personal life, emotional problems, difficulty prioritizing a lot of things coming at the same time, that's how someone with ADHD will probably feel almost on a daily basis. And that's why they often feel paralyzed. They choose avoidance or escapism or procrastination as a way to deal with this really overbearing brain. Dopamine and ADHD, as well as dopamine addiction, are very linked. I don't know if you're aware, but the dopamine can fire in two different ways. We always have a basal dopamine tone, which depends on the activity we're doing. But if we do something that raises our dopamine levels, eating chocolate, having sex, snorting cocaine, different degrees of dopamine spikes. Then we have what we call a phasic, which is kind of a dopamine spike. That is associated with a high, and that reinforces the behavior, and that leads to addiction. The more intense the high happens, and the more quickly after you do the substance, the more likely it is going to be linked to some sort of addiction to that substance. Reward deficiency theories in addiction have been around for a long time, and they're still kind of been hypothesized. In ADHD, we have quite strong meta-analytic evidence that the reward deficiency theories do actually apply, and we know from neuroimaging studies that there's low dopamine tone in people with ADHD, and that explains why they tend to kind of self-medicate, or sensation seekers, they seek this feeling of high because they generally feel much more perhaps miserable on a daily basis, which is quite unfortunate, but tends to be the case in most people. Very briefly, if you give Ritalin, which is methylphenidate, orally, very few people report feeling any sort of high, because it just increases your dopamine in a very kind of tonic way, very, very, very sustained. If you snort it or inject it IV, people do report a high. So yes, ADHD medications, if they're given in a way that increases dopamine very quickly, generally IV or snorted, they can cause a high, which is why, particularly in addiction, we tend to use long-release formulations, which are less abusable, way less abusable, because even if you snort them or inject them, they do not cause this high. Crack cocaine or IV cocaine will cause even a much more massive dopamine spike as compared to nasal or oral type of stimulants. Essentially, medication for ADHD is divided in two big groups, stimulants and non-stimulants. The word stimulants is very confusing. It's a bit of a misnomer here. It just means that it increases dopamine. So for example, modafinil is not a stimulant because it doesn't increase dopamine. It just increases noradrenaline. But you could think of it as a stimulant because it causes kind of increased alertness. So the word stimulant only applies to medications that increase dopamine. They tend to be controlled drugs in most countries. All medications for ADHD also increase noradrenaline, so they improve attention, but only the stimulants increase dopamine. Very briefly, we have short-acting and long-acting versions of all stimulants. Ritalin, which is methylphenidate. The long-release version is called Concerta or Medikinet. And then for amphetamines, we have amphetamines like Adderall, which is not available in the UK. And we have dexamphetamine, which has a long-release version called Vyvanse in the US or Elvance in the UK. This is potentially the medication that's been most frequently used in people with addiction, because the NICE guidelines suggest that it should be used as a first line, but also because it's probably the least abusable medication we have for ADHD. It's a prodrug, so when you take it, it's broken down into the active compound in a very slow way, so it's very, very difficult to abuse. Even if you snort it or inject it, you just cannot get a high from it. All medications for ADHD, aside from improving attention, they help with hyperactivity, they help with emotional control, which is something that perhaps people are not so aware of, and they can reduce impulsivity and across a number of domains. The non-stimulants, they don't tend to be so effective, so less people with ADHD respond to them. They need to be taken daily, so perhaps they're less often used for that particular reason. Whereas the response to stimulants in people with ADHD is quite high, up to 80%. So that's why the NICE guidelines suggests that as a first-line treatment. So when should we treat for ADHD? I mean, there's understandably apprehension about giving dopamine agonists like an amphetamine to someone with a history of substance misuse. The question is, are we turning our children into addicts in a way? And the clear answer from quite a lot of meta-analytic studies is that actually not. And even the most recent studies, not yet included in that meta-analysis, suggest that treating people early on with a stimulant, if they do have ADHD, has actually a protective factor against becoming addicts later in life. This applies to both process as well as substance addictions. This is quite an interesting study worth discussing for a moment. Sweden, very hardcore addict population, 20 years of IV amphetamine use, as bad as it can get when it comes to addiction. 2 weeks before release from prison, they gave them methylphenidate. They gave them 180 milligrams. Now, for those of you who are not psychiatrists, that's a ridiculous dose. I've never spoken to a psychiatrist who has prescribed that dose, let alone not for a patient with addiction. So they gave extremely high dose, more than twice the maximum dose we tend to give. And they did very well, actually. It was a randomized placebo-controlled trial. The ones who received the methylphenidate, the Ritalin, they had less positive urine tests for amphetamines, but also for other drugs. So we know that treating in the right context can reduce a relapse. There's not many studies with this medication that I spoke about earlier. Vyvanse in the US, Elvanse in the UK, lisdexamfetamine is the name of the molecule. But we know that it reduces cocaine cravings, and we look forward to studies being published soon, because this is the medication that we tend to use more in clinical practice. So just very briefly, the NICE guidelines in the UK, they don't mention addiction too much, but they explain that it can be quite frequent in people with ADHD, and that the first line treatment is an extended release, either amphetamine like lisdexamfetamine or other stimulant like Ritalin. If someone is interested in research in ADHD, the International Collaboration of ADHD and Substance Abuse website has a section about research that lists all studies being published, and it's quite helpful. Now, this association published an international consensus very recently, where all the world experts on ADHD and addiction decided on setting out some sort of guidelines for all of us treating ADHD and addiction to follow. And the conclusions were that everyone with a significant history of addiction should be screened for ADHD, which to my knowledge, it doesn't happen across the board at all, but we hope it will at some point. Both substance misuse and ADHD should be treated in parallel. We used to think first treat the substance misuse, then the ADHD. That has changed. Start medication as soon as possible, as long as the person is not intoxicated or has symptoms of withdrawal. That means if someone goes to a rehab for, let's say, a cocaine detox, very early on, because they won't have withdrawals, very early on they should, if they have ADHD, theoretically be treated. All clinical factors as well should be taken into account. Ideally, they suggest long-acting agents, which are less abusable, and they reiterate the concept of going very, very high above the maximum recommended dose, depending on tolerability and response. The rationale is that people with a history of perhaps abuse of street stimulus like cocaine, particularly crack cocaine, they have a down-regulation on the dopamine system. We know, we've tested that scientifically now. We know that the dopamine systems are very dampened. We need to stimulate them with much more medication, because they're not very responsive. Which clinically is a bit of a conundrum, because your patient is asking for more. They feel, they don't feel the effects, and you think, are they asking for more just to get high? Do they need more? So actually, we doctors tend to be quite conservative, but the research is there that we should probably treat with higher doses. When a patient with addiction says, an ADHD asks for treatment with stimulants, we consider many factors before deciding whether to give it to them or not. Mainly whether we can do urine tests, whether they are engaging with an addiction specialist who is closely monitoring them, whether we can talk to the family and see how they're doing, whether they're very committed to reduce or stop their substance abuse. There are many factors that we'll take into account. It's kind of quite a complicated situation, but the UK Adult ADHD Network has perhaps divided this into three more straightforward groups. The red group is quite straightforward. Someone who is dependent on alcohol or opioids, or very heavily using drugs. We don't start medication for ADHD. We have to address the substance misuse, go have a detox. But as soon as they're abstinent, they can potentially be started on medication, as long as there is close liaison with addiction services. The other relatively straightforward group is what they call the green group, and it's people who perhaps binge alcohol once a week, or take cocaine very sporadically, or occasional cannabis use in the evening. Generally, they recommend that it is okay to treat them, and advise them that if they're going to, let's say, drink alcohol on a Friday evening, not take their medication on that day. So harm minimization advice, but they're kind of quite proactive in terms of treating this group. The other group, which encompasses the rest of people with addiction, is a much more gray area, and we need to judge in every individual case. There are a lot of challenges, actually. I mean, the reason why people with substance misuse are often not diagnosed with ADHD even if they have it is because there's a lot of skepticism about the diagnosis. Perhaps people who specialize in addictions don't have sufficient training in ADHD. There's apprehension that they're just looking to get medication for diversion or to abuse it, or there's potentially many obstacles, but I hope they can be overcome. So if any of you wanted to test whether any of your patients have ADHD, there are 2 questionnaires, very good, both of them, which are available online for free. First one is developed by the World Health Organization, the ASRS. It takes literally 5 minutes to complete. It's like one page, 2 sides. If someone scores negative, you can quite confidently say that they're very unlikely to have ADHD, so they don't need an assessment. So it's quite helpful. If someone does score positive, it's helpful to have an assessment. But very often, the psychiatrist or the person who does the assessment will say, well, they do have some ADHD traits, but they don't meet the full diagnostic criteria. So that's what we call a false positive. But it is best to have false positives than to miss people. So this questionnaire has been very well tested in that regard. Now, we tend to prefer the DIVA, which is another questionnaire that's freely available online if you Google DIVA ADHD, because it's much longer. It includes symptoms about childhood. And actually, I encourage every one of you, if you want, to kind of print out a copy of this questionnaire and just self-administer it yourself. It will probably take 10-15 minutes, but you will get a very good understanding as to where you are on the ADHD spectrum. All of you will tick some boxes, and you will understand very well to what extent perhaps you struggle with some of the domains or not. And when dealing with a patient, you will be able to use your own the way you relate to ADHD in terms of how another patient scores differently. So it's a very didactic questionnaire, and it's the one that most psychiatrists nowadays tend to use for screening and diagnosing ADHD. Now, kind of to conclude, ADHD and substance misuse, they're very linked genetically, neurobiologically, and also kind of behaviorally. So we have to suspect or screen for ADHD when we have someone with a significant history of addiction, any type of addiction, again, process and substance. ADHD is very common amongst people with substance use disorders, and it's really underdiagnosed. The treatment for ADHD can potentially improve outcomes in people with addiction, but every case is quite individual, and ideally you want to work quite collaboratively with addiction services, with the psychiatrist. You want to have a proactive approach, but of course kind of monitor very closely. And the most recent research, although not yet confirmed by meta-analysis, suggests that really people with ADHD who have substance misuse, when you do treat the ADHD, they seem to do much better in terms of relapse prevention, but also in terms of better control of their ADHD symptoms, better quality of life. And that's it. I'm glad that I was on time. Thank you.